So you can see over here, this is the internal carotid artery that gives off the anterior cerebral artery and the middle cerebral artery. In the anterior cerebral artery, you can see this is the first segment, the A1 segment of the anterior cerebral artery before this anterior communicating artery. And after the anterior communicating artery is the A2 segment of the anterior cerebral artery. And this is the middle cerebral artery with the first segment M1. And this is a bifurcation. You can see this is the M2 segment. I will also later tell you that there's a lack of decision of the demarcation of the M1 and the M2 sections, M1 and M2 segments of the middle cerebral artery, and I will discuss it in detail. So after this M2, you can see overhead is the M3 segment of the middle cerebral artery. You can see it on this lateral view as well. This is the coming off. Okay, you can see overhead this is the ophthalmic artery coming off, and this is the A1 anterocerebral artery over here is the anterocoroidal artery. You can vaguely see over here, and this is again you can if you just give it a little view, a little more focus. This is the M1 MCA and the M2 NCA, and this is and after this A1, you can see these are the two bilateral A2 segments, and these are the A3 segment, the callus marginal the peculus and the is a marginal artery that you can very well see here. I will show you more later. So again, if we are going into the middle cerebral artery segments, you can see this is the M1 horizontal segment, which is derived to these lateral lenticular striate arteries, which supply the part of the head and the body of the caudate, globus pallidus, putamen, and the posterior limb of the internal capsule. And you need to emphasize a little point over here that in the lenticular striate arteries, the lateral arteries arise from the horizontal segment of the M1 artery, but the medial lenticular striate arise from the A1 segment of the anterior cerebral artery. So after that, like I have told you, I will just later to tell you in the details that there is actually the point where the M1 sphenoidal segment becomes M2 insular segment is not quite agreed upon. So in this picture, you can see that this is the horizontal segment, and they consider it as the M2 sylvian segment, where the branches supply the temporal lobe in the insular cortex, the sensory language area of the Wernicke's, and parietal lobe sensory cortical areas in the intralateral frontal lobe. And then you can see these are the cortical M3 branches that supply the lateral cerebral cortex. So the point with the M1 sphenoidal segment become the M2 insular segment is not quite agreed upon, as I have mentioned before, as originally described by Fisher in 1938. The M1 segment ends where the artery runs. Although their bifurcation coincides with the geno in the classically described anatomy, most patients have a non-classical bifurcation that occurs proximal or distal to the geno. Thus, the M1 could include rather than necessarily end at the main bifurcation. This Lankbard-based nomenclature was adopted in Gibo and Rotten's microsurgical descriptions. In contrast, in the current era of endovascular interventions, the stroke experts groups have recommended the designation that the M1 ends at the main bifurcation. Different studies still variably define the M1 and M2 distinction. So this is important for you to have an idea. So here, if you can see, this is the M1 sphenoidal segment. If we say like this, or horizontal segment that originates at the terminal bifurcation of the internal carotid artery, and it courses laterally parallel to the sphenoidal ridge. And this then comes this M2 segment. This is the insular segment that originates at the genu or the limb insulae or the main bifurcation course, or the main bifurcation, and courses posteriorly in the insular cleft and terminates into the central circus of the insula, where it makes the right or the hairpin angle. You can see over here, it is going into this insular segment, going into and again you can see this is causing this hairpin turn, and then comes this M3 upper segment. Okay, this is the segment that originates at the circular surface of the insula, courses laterally along the frontoparietal operculum, and terminates at the external superior surface of the fissure, the sylvian fissure. And then comes this M4 cortical segment that originates at the external top surface of the sylvian fissure and courses superiorly on the lateral convexity and terminates at the final cortical territory. And interior cerebral artery, it again it has got 5 segments, like I've told you before. In the angiogram you might have seen these pictures. So you can see this the A1 segment that is before the interior communicating artery, and after that is the A2 vertical part you can see over here. And then comes this A3 precallosal segment before it takes this type of a turn. This is the precallosal segment, and extend around the genu sinew of the corpus callosum are distal to the origin of the callosum-marginal artery and terminates with the artery turns directly posterior above the corpus callosum. Okay, so it then it just turns, and then we start to have this A4 supracallosal segment of the body of the corpus callosum anterior to the plane of the coronal suture. Okay, so if you have this idea and you want to have this idea, it's very important for you to have this point in your mind. And then comes the post callosal segment of the body of the corpus callosum that is posterior to the plane of the coronal suture. So the coronal suture, the plane of the coronal suture is important for you to demarcate A4 and the A5 segment, and the segment of anterocerebral artery that is anterior to this plane of coronal suture is the A4, and that the part of the anterocerebral artery that lies behind it is the A5 post callosal segment. This is the circle of Willis, which encircles the stalk of the pituitary gland and provides important communications between the blood supply of the fore and the hindbrain. This is between the internal carotid and the vertebrovascular system, following the obliteration of the primitive embryonic connections. So you can see over here, again, you can see all these important arteries. Like I have told you, this is this coming up with this. So you can see over here this internal carotid artery. This is the A1 branches, and this will be the anterocerebral artery, and this is the anterior communicating artery. And here comes the middle cerebral artery, and you can see it giving off these M2 branches later on. And if you see over here, this is the vertebrovascular system, these two vertebral arteries that form the basilar artery, and they divide into these posterior cerebral arteries. And this is the posterior communicating artery over here. Now coming towards the blood supply of the brain. So if you see there are three important arteries over here at the anterior, middle, and the posterior cerebral artery. So you have to see that the middle cerebral artery supplies the majority of the lateral surface. And you can see we have used this color, quite pinkish color, to show you. This picture is from the geekymatics.com. I'm really thankful to them all who have provided all of these amazing things on their websites. So if you want further details or you want to go into these websites, you should rather, I would recommend you to visit these websites as well to have a deeper idea, or maybe a new perspective. Because what I have done is I have taken so many things from my own mind, and I have then tried to gather much knowledge that I thought was important and that was helpful for us. So I tried to gather everything that came into my mind from various different sources. So you can see over here, this is the middle cerebral artery that supplies the majority of the lateral surface of the hemisphere, except the superior portion of the parietal lobe via the anterior cerebral artery. You can see the anterior cerebral artery has been denoted with this yellow shade. So the inferior portion you can also see over here, and you can just see this violet, bluish violet color. This is the posterior cerebral artery. So you can see that except for these two places, anything else on the lateral surface, everything else is from the middle cerebral artery. So except for the superior portion of the parietal lobe, which is supplied through the anterior cerebral artery, and the anterior portion of the temporal lobe and the occipital lobe, which are supplied by the posterior cerebral artery. And coming on the medial surface, the AC supplies the medial and superior part of the frontal lobe, that you can see over here. The medial surface is supplied, the frontal lobe even is supplied from the anterior cerebral artery, as well as the superior part of the frontal lobe. And then comes the anterior parietal lobe, that also supplied by the anterior cerebral artery. So this is important for you to have an idea if you are dealing especially with cases of ischemic stroke. So you can have this idea to know which of the vessels has been involved by the ischemic stroke. And for neurosurgeons, the cerebral aneurysm is, which is also known as the brain aneurysm. It is a weak or thin spot on an artery in the brain that balloons or bulges out, and it fills with blood. The bulging aneurysm can put pressure on the nerves or the brain tissue, and it may also burst or rupture, spilling out blood in the surrounding tissue, which is referred to as the subarachnoid hemorrhages. And we deal with them almost, I guess, very, very commonly, because we have seen them so much in our practice. Cerebral arteries are vulnerable to aneurysm. So why they are vulnerable? You need to know and to have an idea about this too. It is because of their very unique structural properties. Compared to their systemic vascular counterparts, the cerebrovascular arteries they differ by having an extremely thin adventitia. That is, the adventitial layer is quite thin over here. And absent external elastic lamina uh, is very important for you to remember these points, and a medial layer that is characterized by decreased elastic fiber density. Additionally, in lieu of connective tissue, these vessels are surrounded by the subarachnoid CSF. The internal elastic lamina located at the circumferential junction between the intimal and the medial layer is largely responsible for preserving vessel wall geometry, and damage to the internal elastic lamina and resultant loss in the vessel elasticity is the seminal event in saccular intracranial aneurysm development. So, I also want to tell you that the cerebral aneurysm is the most common non-traumatic cause of subarachnoid hemorrhage. Aneurysmal rupture typically present with thunderclap headaches and focal neurological deficit, and has an all-cause mortality of roughly 50% at 6 months. And before this, you might see that your patient have complaint of having some what we refer to as the sentinel headaches or the warning headaches, where the patient might complain of headache before the actual rupture of this aneurysm. So there are types of aneurysm can be fusiform aneurysms, which in which you can see the whole of the vessel wall has bulged or ballooned out in all sides of the blood vessel. And not the most common one. I think this is a wrong statement, which is being you know not quite commonly seen in the brain. We have not seen that much. We usually come across the saccular aneurysms that bulge out only on one side, and they are the most common type of cerebral aneurysms. So actually, not for the cerebral aneurysm. If we say fusiform aneurysms, uh, in the cerebral anatomy, this is not the most common aneurysm. In altogether, we might have this fusiform aneurysms elsewhere, like in abdominal aorta, but in the cerebral circulation, the saccular aneurysms are most common, and we really, I think, in my own experience, I have seen about 2 or 3 patients at the most in fusiform aneurysms. So you can see over here, you have can you see this? Can you appreciate this is an aneurysm over here? This is an arterial communicating artery aneurysm. You can see this little white type of balloon outpouching. And what we do in neurosurgery, we apply a clip over here. You can see to obliterate this aneurysm, to separate it from the main circulation. Can you very well appreciate it? Uh, and now we are coming to the vertebral basilar system. So the union of the vertebral arteries at the pontomedullary junction. So you can see, as I have told you before, these are the two vertebral arteries that join together to form the basilar artery that runs along the basilar groove or the basilar circles on the ventral surface of the pons and the pontine cistern. Like I have told you before, the CSF cistern, the subarachnoid cisterns are important for vascular surgeons. So you need to remember this. They bifurcate into paired posterior cerebral arteries. And the branches along the course of basilar artery gives off 5 major branches that include the anterior and posterior cerebral arteries. You appreciate it over here. If you just follow this along, you can have this idea. This is the superior cerebral artery. Can you see over here that it's arising from more superiorly? I think I have more pictures for you. And then this is if you follow it, you can see this is the labyrinthine artery, and the anterior inferior the arca is coming off over here. Okay, and for the posteromedial arteries and the pontine arteries, and they obviously did, but they terminate at the bifurcation where they give off the paired posterior cerebral arteries.